Thank you, everybody, for joining us for our third and final round of student lectures. We are very excited to have Kate present in healthcare. Taylor will be talking about healthcare and cognitive engineering. Pengyuan will be talking about formal methods in cognitive engineering. Pedro has healthcare as his topic, and Robin will be talking about cognitive engineering and flight performance. So this is a nice variety of topics and lengths of presentations. After each presentation, we're going to have an opportunity for about a few minutes of question and answer before moving on to the next one. So please take advantage of the Q&A tool during the presentation so that we can queue you up and people can add comments and upvote your questions to move you further up in the queue if we are short on time and have to pick and choose between our inquiring minds. There also is the networking directory that will allow you to reach out to the presenters directly, especially if we run out of time. And our presenters are here live, but if we run into technical difficulties, we're going to switch over to a pre-recorded presentation that they have on backup. So if that happens, please hang tight. Kate, are you ready?
I'm ready.
Great, go ahead.
Okay. Thank you very much, Megan. Hello, everyone. So my name is Kate Kazlovich, and I'm a PhD candidate at the University of Toronto with the Institute of Biomaterials and Biomedical Engineering. And I also am partnered with St. Michael's Hospital's International Center for Surgical Safety, where I work on a project that revolves around the development and evaluation of non-wearable multi-camera system for intraoperative video recording of open surgery. I know it's a mouthful, but I'll explain what it all means. So today we're going to go through some of the background of this project. We'll talk about the OR black box, some of the recent literature findings in the space of open surgery and use of video recording technology in that space. We'll then discuss some of the gaps and objectives of the research and review sort of current work and challenges. And this is where, at the end of the presentation, I'm really curious whether or not you guys have some questions or suggestions as human factors engineers. I'm very excited to share this with you. So without further ado, first let's discuss what is OR black box. So the OR black box is a system that essentially captures and synchronizes several sources of intraoperative data and then produces outputs such as assessment of risks and hazard or identification of safety issues, performance evaluation, assessment of surgical technology, and overall efficiency of the procedures. This sort of idea of black box was inspired by the aviation industry. As you know, in the aviation, we have black box where if something goes wrong, you can go back and sort of review the data and then analyze it and hopefully eliminate the mistakes, identify them in order to prevent them from happening again. And this was what really inspired this idea of introducing OR black box for surgery. And right now, in this current setup that we have at St. Michael's Hospital, for example, we have OR black box that looks at the trauma, COVID black box, and also SIM black box. And for the purpose of this presentation, I'm going to focus on the standard operating room black box. So some of the current limitations that we have with the system, excuse me, is that right now, we're recording data from the intraoperative data from minimally invasive procedures mostly. And what it means is that right now we can record audio in the OR. We have video cameras positioned on the perimeter of the operating room on the walls. And we also have the control panel that initiates the data recording and acquisition. And we also record data from actually the patient because we have the laparoscopic tools equipped with very high definition cameras. Now, all of this is really great because we have been able to prove that this sort of access to data allows us to perform really efficient analysis and extract a lot of meaningful information that can prevent us from making mistakes in the future. However, there is, excuse me, I'm losing my voice. However, there's an inability of currently for us to capture OR black box in open surgery. And while one may think that minimally invasive procedures are becoming more prominent, there's still a significant number of open surgeries that are being performed on a daily basis. And this is a quote from a student, a surgeon that has done some work prior to my research. He has stated that the inability to capture continuous and reliably high quality intraoperative video from open surgical procedures really limits translation of the OR black box platform to open surgery. And the further development in this field, specifically with the camera systems, would help us to obtain better data, get integration and connectivity, and may serve to provide the missing link for the OR black box analysis for open surgical cases. And the proposal, the outcome of his review of the system was that to capture video recording of surgical one side with non-wearable depth camera and employ instant segmentation method in real time to address occlusion issues is something that we can really look into in order to address this gap. So in prior work in open surgery, there's been a systematic review that looked at all of the different technologies that have been implemented in order to record open surgery. Some of the more prominent ones, as you can see in these graphs, are technology like the GoPro camera, which is a wearable technology, camcorders that used to be fixed on the side of the bed, for example, or even technology like Google Glass, which became extremely popular when it just came out and everyone wanted to test it out. Now, the key limitations identified through these systems across all of these systems were related to data management issues, the incorrect field view and incorrect line of sight or parallax. And what it means is when the surgeon is looking into one direction, for example, if you're wearing a device on your head and you turn away from the field of interest, such as the wound, then you're looking maybe at the nurse or at the tools, or you're essentially being distracted away from the area of interest. And then obstruction by surgical team. So in the operating room, when you are performing open surgery, what happens frequently is there are a lot of people that are either assisting you, or in some of the teaching hospitals, we also, of course, have students. Maybe you're educating someone how to perform a procedure. And so as a result, we have a lot of people in place that are circulating around the table. And that is very different from the minimally invasive procedures in which you just access the field of view through a keyhole, right? You have your laparoscopic tools, and it's basically provides you with the unobstructed sort of view of the inside of the body and the area at which you're performing the procedure. So that's kind of like a key difference and one of the challenges that we'll discuss later. And so one of the alternative solutions that have been tested prior to this research has been this idea of using a prototype system. In this case, it's a wearable prototype system. As you can see, it's a shoulder mounted system that was compared against a standard GoPro setup that is mounted on the head of a surgeon. And in order to evaluate this proposal, we implemented some of the machine learning techniques to see how much of the proposed view, like surgical view, would be occluded with one of the systems. The objective evaluation technique is also something that has been developed as a result of this research, because we realized quite soon that unfortunately, with a lot of previously evaluated camera technologies, the majority of the evaluations have been performed on a qualitative scale. So there's either a Likert scale, or maybe there was a questionnaire, or just a general feedback that was collected from the surgeons that have been using these cameras. There wasn't really an objective way to evaluate performance with something like maybe a computer vision technique or a mathematical model. So another issue that hasn't been really addressed is the occlusion issue with the GoPro or the shoulder-mounted prototype. That's something that came out of this research. One of the reasons this prototype was on the shoulder is to address issues associated with the head movement in the recording of these surgeries, or as I mentioned, when you turn away from the work that you're doing and looking in a different direction, of course, the camera looks in a different direction as well. Whereas with this shoulder-mounted prototype, the camera was able to pivot on a gimbal system and then always focus on the area of interest, as you can see in this image on the top here, because we were implementing essentially a computer vision algorithm that was allowing us to focus the camera on the wound. So one of the key takeaways from this research was that the proposed solution did improve in terms of its performance and ability to capture most of the procedure. However, one of the ideas that came out of this was to look into a multi-view camera setup. And so as a result, we started to look into this as of last year. And here's some of the examples of also alternative multi-view camera setup that has been explored by other universities like University of Japan. That has essentially developed an integrated solution in the OR light, and they have proven as a concept that this strategy works really well. There's also been research at the Vanderbilt University that has shown that performance of instant segmentation and detection of surgical wounds in open surgery can be done with a rather limited data set, which is important because, as you can imagine, in this field, it's really hard to acquire data because you need to get research ethics board approval. And of course, sharing of these data sets are not very common at this point in time. And so the key benefits of Toronto study were the objective and subjective evaluation techniques that came out of this. The key benefits of Japan study were that the automatic switch point between different camera views in the multi-camera setup essentially provides us with an option of selecting which view can be prioritized, as you can see in this image at the top. So if you have 5 different points of view, at any point in time, you can select which one is the best one, as in the least occluded point of view. And the key benefit of US study was, of course, proving that the mask RCNN model can work on the relatively small data set. And the mask RCNN model is just a convolutional neural network model to train essentially a program to recognize whether it's looking at the wound or tool or hands and whatnot, and be able to track this area of interest. And so with the multi-view cameras, in my research, I'm looking at the improvements in the following areas. I'm looking at the ideas of integrating this multi-view solution with the OR lights in a more add-on fashion, as opposed to providing a fully integrated solution, because one of the problems with having a fully integrated camera with the OR lights is that, of course, you can just bring this OR light into every single hospital. Let's say in Toronto or US, they're usually already equipped with some sort of OR lights, and it's really expensive to replace this or have to essentially take it down and then remodify it to fit the cameras. So one of the alternatives that we're looking at is sort of an add-on solution. Another thing that we're looking at is the exploration of surgical procedures. So majority of the studies in this space that have been performed up to date have been performed on plastic surgery. And of course, at this point, we're wondering how that would differ if you were to deploy these solutions in a different surgical domain, such as cardiac, let's say cardiothoracic, orthopedic surgery, or other types of procedures that could have a multi-dimensional sort of level of complexity, as opposed to plastic surgery, which most often happens on the surface level. And of course, lastly, I'm looking into development of a more standardized video quality evaluation technique that would be addressing current issues and building upon the research that has been done prior to my PhD. So the research gaps, as I mentioned, is there are no examples of comparison between standard RGB and RGBD depth camera multi-view systems that can be used to capture open surgery. We have not been able to develop a standard quality of video evaluation technique that would be able to assess sharpness, brightness, zoom, and occlusion. We have not been able to answer questions about how the application of such data capture system would be performed in different surgical domains. And we need to further validate and improve these evaluation techniques. So right now I'm working essentially on the development of my own multi-view camera system for open surgery that will be able to eliminate the field of view occlusion issue and compare performances against recording capabilities of most commonly used point and shoot camera systems. In my case, I'm looking at the OR light integrated camera and also a shoulder mounted wearable camera. And then I'm going to perform objective evaluation techniques on all 3 different modalities and see how they fare against each other. The objective, as I mentioned, is to implement a framework for transfer learning, to perform instant segmentation of hands, tools, surgical caps, and wounds. These are the objects that I'm interested in recording in order to be able to tell my camera what percent occlusion I have in each data set, and then prioritize a specific image during recording. Then I'm also going to perform the test of RGBD versus RGB camera system. And finally, I'm going to implement the objective evaluation techniques on all 3 different data sets in order to identify these unique challenges associated with data collection and subsequent processing. So because I know that I'm talking to a lot of human factors engineers today, I wanted to pose some questions at the end of my presentation. As of this moment right now, I'm working on the primarily hardware system, and I'm training my model in order to improve sort of its output and accuracy. I'm expanding and also annotating a data set for open surgery. However, outside of that, I'm really wondering in terms of the integration of the system in the OR. From the human-computer interaction system perspective, I wonder what should this system look like in the future in terms of being an add-on or being something that should be like standard across the board. What functionality would be important for this system overall? And then in the future parts of my study, I'm also looking into developing a camera rig. So some of the questions that I have to answer relate to what should the features of this camera rig be mandatory, such as, for example, if it's an add-on system, where should be added? If it's integrated with some sort of interface, like the one that we have on the wall right now, what should that interface look like? Or should it be controlled externally? And of course, objective evaluation and feedback is something that I'm also looking into in the future, is understanding how this feedback and objective evaluation will differ across different surgical domains, because as you can imagine, every procedure is quite different in terms of the number of people involved, in terms of its complexity, and in terms of its length. So it would be really interesting to see how plastic fare against cardiothoracic or, I don't know, neurosurgery, for example. And that's it for today. Thank you so much. I apologize for my voice breaking through the presentation. I really appreciate any feedback or suggestions, and happy to answer any questions.
There we go. Thanks, Kate. We're a little bit short on time for questions, but you posed some really good ones, and that's fascinating research you're doing. What I suggest is throw those 3 questions that you had into the chat, and I encourage all of the attendees to reach out to Kate through our networking directory, and you have her email address, and then you can go ahead and continue the conversation with Kate, maybe get a coffee virtually sometime with her and talk more about what she's doing and give her some suggestions. And then I see another question popped up in the chat, and I would suggest the same thing to you. If we do have time at the end, then we will come back to Kate if we can. Next up is Taylor. Are you ready?
Yes, let me share my screen for you. All good?
Yes, thank you.
All right. So I'm going to talk about patient context and making patient context concrete. And I'm going to talk briefly about and using an abstraction hierarchy to bring in this contextual care specifically for medication use and some of the other directions that I will be taking with my dissertation on this. So to reiterate, my name is Taylor. And I'm from the University of Buffalo. So before I get into this, I just want everyone to kind of think about maybe their last experience at the doctor's office, or a time when they were there and they were talking to their provider about what they needed and what they wanted out of the visit or about their treatment, and how well that treatment or whatever plan you decided on matched what you needed based on what was going on in your life. And as an example for myself, I'm very bad at taking medication. I'm supposed to be on vitamins and different supplements to kind of boost my system, and I'm horrible at taking those. So my doctor and I have been trying to figure out a better way to get my system the vitamins that it needs without my going out of my way to take an oral medication that I'm going to forget. So the kind of beginning of this is looking at patient-centered care. And patient-centered care was introduced in 2001 by the Institute of Medicine as an objective for improving healthcare. But the problem with this is that it's really easy to define a patient, and it's harder to define patient-centered care. So the Institute of Medicine describes this as a partnership between patients and providers in order to ensure that medical care actually reflects patient preferences. And this is why the power of patient voice is really important and why it's such a hot topic right now, that patients actually have a say in their medication, in their treatment options, and everything going forward, and that there is a match. I apologize if you can hear my dog tapping in the background. But why it's so important to get patients on board, because then they will be more satisfied with their care and more adherent to any treatment plans going forward. So looking at patient context, there's a ton of different lenses that you can use to look at patient-centered care. And the two that I'm going to talk about today are social determinants of health and contextual care. And social determinants of health are just non-medical factors that influence the patient's quality of life and their health outcomes. And these span the 5 different dimensions here of economic stability, healthcare access and quality, social and community context. So this is going to be the people that we surround ourselves with, education, access and quality, and neighborhood and built environment. And that's the physical environment, not just the people in our environment. And then contextual care refers to the recognition of those values, preferences, care goals that will be incorporated into treatment. And some studies have looked at how we can categorize maybe some red flags related to contextual care in order to identify if providers are actually meeting those or not. So these include uncontrolled chronic conditions, adherence to appointments, adherence to medication, resource utilization, and et cetera that I've listed here. So why study patient context? So as I've said, it gains patient buy-in. They can meet their stakeholder needs. And then it's matching not just the biomedical needs, but also their social needs. So what's going on in their life? Can they actually afford to match this plan? Can they afford maybe the surgery that they need at this time, et cetera? And there's a lot of different parties involved: the patient themselves, maybe their caregivers, their provider, other specialists. So interventions looking at how to incorporate patient context are currently limited. There's not a ton of tools. There isn't a lot of information as to what the best time is to implement those, how to implement them, where in that treatment cycle they should be introduced. There's not really great metrics to measure how well this is working. It's very subjective, and it's very reliant on feedback, or maybe the overarching organization saying, yes, you're doing this, or no, you're not. That also requires a lot of buy-in from the practice itself. And then looking at patient context, there's a lack of standardized data collection tools. So you would think it's really simple. You just talk to the patient, right? But it's not that simple. You can't just ask everything, and sometimes you don't know what to ask because it hasn't even come up on your radar that that's important. So the medical interview is a guided conversation, and it goes through different communication skills at various points in the treatment process or in a well visit to help providers get all of the information they need. But it's really important to look at just who you're talking to, whether it's a patient or a caregiver. Maybe you're talking directly to the physician, maybe you're talking to a specialist, or a lot of times you're having some of these really important trust building conversations with whoever is doing the intake. So that might be a nurse, an assistant, an intern, someone that's bringing you back to the room, and then they have to relay the information to your physician in a very limited amount of time. So who does this benefit? Who can really benefit from patient-centered care? Well, obviously the patients. In my study, I'm going to limit it to looking specifically at adults with type 2 diabetes that fall into one of 3 categories. I'm going to look at individuals who are newly diagnosed with type 2 diabetes, those that have experienced the disease progression where there is an introduction or a change in their medication, so their oral medication, a tablet or a capsule, or there's a disease progression where they have the introduction of insulin. And then for providers, I'm looking at primary care physicians because they manage chronic care and they're kind of that main point of contact usually with the healthcare system. But I'm also going to look for input maybe from nurses, pharmacists, specialists as needed. And I'll determine that a bit more later in my study. So how do we actually get contextual information into the hands of those making the medical decisions? So far, I've looked at a lot of literature, looking at this point, and a lot of academic literature, but a lot of informal web searching as well, just to see what kind of blog posts are there, what are people talking about maybe on Facebook that I can see, et cetera, to see what is important to patients. And then looking at discussion with healthcare professionals, and this will come up more later as well. So I do have an initial abstraction hierarchy that I've been working on. It is not a complete model yet, and it does need to be finalized and validated with actual providers currently, because I obviously don't have that medical experience. That's their area. But this is what it looks like at the moment. So unlike some other abstraction hierarchies in the past that have looked at managing conditions for the patient, this doesn't necessarily look at just the biomedical aspects or what the provider can control. And it is going to be limited to medication specific instances that the patient is working on, but it's going to look a lot at their social context. So the patient themselves is the boundary to this system. So you can see things on here like minimize patient's burden of treatment. Does that medication regimen or insulin regimen, et cetera, match what they can physically or mentally, emotionally handle, or is it putting too much of a burden on them? Down in the object-related processes, we see patient self-management of conditions, and this is looking not just at their medication regimen, but their ability to actually go to a healthcare facility, their ability to store their medication properly, either at home or if they have to travel, looking at any lifestyle modifications that they might need, exercise, diet, substance use, et cetera. And then it's looking at how we can incorporate all of those back into this hierarchy to see not just does it help maintain or improve the patient's physical health, but does it maintain or improve their quality of life? Because I don't know about you guys, but for me, I can have the best health in the world and still maybe not feel good mentally if I can't do the things that I want to do to make me happy in life as a result of needing to maintain my physical health. And that is a tough balance to achieve. So this abstraction hierarchy will eventually be used to pull out different questions that can be incorporated into a tool and help identify questions as well to ask providers and patients when I conduct semi-structured interviews with them. So my next phase moving forward, I have 3 phases. First phase is looking just at what contextual information can patients provide and what do providers need. So I'll finalize that abstraction hierarchy. I'll be looking at some semi-structured interviews to flesh out a decision ladder and looking at some thematic analysis and free coding to see what can providers tell me about what they have going on in their life, what do they think their provider needs and what can they provide, and vice versa, what does the provider think they need, what can they provide, etc. In phase 2, I'll actually look at translating all of the information that I get from the abstraction hierarchy, the decision ladder, and that thematic analysis into the development of a tool. And then in phase 3, I'll actually evaluate that tool to see, one, does the tool meet usability testing? Is it pleasing and easy to use? And then using potentially a modified Wizard of Oz technique to say, okay, the patient maybe clicks on a button that indicates they would have asked this question to the patient, and then it will use a code to say, okay, this would be the patient response, and a think aloud protocol to determine if there are any changes or how their decision-making process might be different with the inclusion of that contextual information or not. So thank you guys so much. If there's any questions at this time.
Thanks, Taylor. That's really interesting, especially when you think about how, I mean, it's not just the burden of having to take the medicine, but a lot of people stress about whether or not they can afford the medicine, and the patient-centeredness of, you know, doctors prescribing meds that might not be the best fit, but work within somebody's financial budget and some of that. So very, very interesting topic that you're coming at from a nice angle. Does anybody have any questions that they would like to ask? So Taylor, if any questions come up after the fact, somebody might be trying to find their keyboard or something to be able to type out to you right now. But if they come up, we can always come back to them at the end, or you can answer them directly in the Q&A. And then also people can reach out to you directly using the networking directory. So next up is Penguin. Are you ready to go?
Oh, yeah. So I'm sharing my screen. Okay. So hi everyone, I'm Pengyuan and working with my advisor Dr. Bolton. And our group's name is a taxonomy for force functions for addressing human errors in human-machine interaction. So I will introduce what human errors and force functions at first. In the safety critical systems, like those used in medicine, industry, and aviation, human errors are often associated with accidents and disasters, while the humans are often being blamed for problems associated with errors. These are actually typically arise because of the poor system design. Thus, through improved system design, we can help to prevent errors from occurring. With a deeper understanding of human errors and the development of task analysis techniques, we can understand why the error happens and predict the potential human errors. And now, how could we improve the designs? That's where the force function comes in. A force function is a constraint, a strong constraint, that is enforced on the system to prevent error from occurring. For example, the message box to prevent you closing an unsaved Word document is a force function. Also, the USB sockets that prevent incorrect code from being plugged into them are also a force function. As you can notice, the force function can be effective for human error, but sometimes the design can also put a lot of restriction on user, and human user may not always be able to respond to the unexpected situation in the system. And the overall constraint could hinder the system resiliency. The accident in this video is an example of how force function can impact system resiliency. The force function for preventing pilots forgot to put down landing gears. They actually caused an accident because in the show that they doesn't need this behavior to land along the landing gear. There are actually already have some general approaches attempt to help engineers to prevent errors. This includes the barrier series and the poker yoke, obviously the mistake-proofing devices. However, these systems the guidelines are vague and incomplete. Thus, there are little formal guidance exist for how to apply force functions for specific errors, while enabling engineers to be fully cognizant of intervention trade-offs. So we are creating a taxonomy for force functions to fill this critical gap. This will arrange the different force function and the barrier concept from across of the literature in the hierarchy. That will show when and how to restrict human behavior and eliminate an error while minimally impacting resilience. And here is our hierarchy for the taxonomy of force functions. Our hierarchy have two broad categories. The hard force functions are those that specifically constrain the human input to the system. That is, the actions associated with an error are not allowed to occur. For example, in a software interface, user couldn't access a disabled button no matter how much time the user clicked it. And software functions worked by constraining the human behavior through the changes in the system information displays and trainings and management practices. Thus, with software function, human can still perform a given error, but he or she will be discouraged from doing so to the condition of the system. And there are three hard force function methods that we have adopted from the work of Don Norman, the interlocks, lock-ins, and lockouts. In our taxonomy, we define this using concept of human tasks. And specifically, a human who makes an error will have a larger correct task that he or she is trying to perform. And an error that occurs will constitute to some erroneous task that he or she wants to perform. And in all the hard force functions, we use the Venn diagram to show when actions from these tasks and possible tasks are allowed to occur in the white area. And the actions are blocked from occurring, we use in the blue area. Also, the patent field in the interlocks are indicated that these associated task actions are allowed to occur, but with additional restriction on order. And an interlock is the most restrictive of the hard force functions. It ensures that the system only allows the action associated with the correct task. And these actions also need to be executed in the specific sequence and specific time dedicated by the task. The next up is lock-in. This ensures that the system only allows action to associate with the correct task to occur. And it's less restrictive than interlock because it has no restriction on the action ordering. And finally, we have the lockout. The least restrictive of the hard force functions. In lockout, only the actions associated with the erroneous task are prevented from occurring. And next, we move on to soft force functions. We identified two types of soft force functions. The symbolic force function uses the design of the interface or the environment to prevent an erroneous behavior from occurring. For example, a sign in the work environment can actually provide a warning against an unsafe behavior, or a checklist that can be used to help a worker to stay on task. And the incorporeal force function seeks to change the way the human thinks about the task in order to prevent an error. This can include things like the worker training, as well as the use of management practices, rules, regulations, and laws. For example, adopting a safety culture practice will put on the social pressure on employees for them to follow safety procedures and thus preventing errors. The taxonomy hierarchy is arranged so that the interest at the top represents the most behavior restricting and thus the error preventing solutions. And as you move down from the hierarchy, the restrictions become less severe. This means that the lower entries of the hierarchy have the potential to be more resilient than the one above. And this, at the same time, it will also allow more erroneous behaviors. And in conclusion, this hierarchy is actually our first step towards creating a formal guidance for selecting forcing functions to fix errors in the human-machine interaction. And currently, we are mapping the human error types from the formal classification taxonomies to the forcing function types, and enable engineers to select forcing functions that will address a given error while minimally compromise the resilience. And also, it's important to note that more than one sort of forcing functions can be employed, even in the presence of the hard forcing function. Because of this, we're investing on how engineers can combine forcing function concepts for the maximum effectiveness. And finally, we are collaborating with the teams of computer scientists at the Carnegie Mellon to determine how our hierarchy can be used to automatically fix system designs that can cause human errors. And thanks for listening.
I always forget to applause because we're on a video and you're not used to clapping to the TV. But thanks, Juan. That was a great presentation. And we do have just a couple minutes. If anybody has any questions, go ahead and throw them up into the Q&A. Okay, and if any come in later, we can always have Juan address them through the Q&A feature in writing, or if there's time at the end, he can answer them verbally. Our next presenter is Pedro. Go ahead, Pedro.
Okay, thank you. Just let me put my slides here. Okay. Okay, can you guys see can you guys see my full screen with the slides? Okay, perfect. Good afternoon, everyone. My name is Pedro Velmovitsky. I am a third-year PhD student at the School of Public Health and Health Systems of the University of Waterloo, under supervision of Dr. Plinio Morita, and I'm very happy to be here at IUW and present my work titled Mobile Health Platform for Individual and Population Surveillance. So my work focuses on public health surveillance, which is the collection, analysis, and dissemination of data to improve population health. One of the main sources of data are surveys, such as questionnaires and interviews, which have several limitations related to self-report, such as social and recall bias, losses due to follow-up, delays between collection and reporting, and costs and logistics. An alternative here is the use of mobile, wearable, and Internet of Things, or IoT technologies, such as smartphones and smartwatches, as additional survey and assessment tools. Smart technologies have sensors that provide real-time and zero-effort monitoring of vital signs, environmental variables, and behavioral metrics, such as heart rate, temperature, movements in the house, among others. Sensor data are also continuously measured, providing richer and more representative information. Currently, to reduce the spread of COVID-19, individuals are also being asked, as we all know, to self-isolate, making clinic measurements and in-person interviews extremely difficult. And in addition, social distancing for large periods of time can have adverse effects in the mental and physical health of populations. Connected devices that can safely monitor the health of individuals can be of great help during the pandemic and highlight the pressing need of using personal devices for public health surveillance. So as an example of the benefits of personal devices to public health agencies, we can consider the Canadian Health Measure Survey, or the CHMS, which is a major Canadian survey comprised of an hour-long interview in the respondent's home, a visit to a clinic to collect physical measures, and the use of a fitness tracker for a week. Most of the measures in the survey, such as body composition or heart rate, can be collected using smart technologies, which can reduce biases. Incorporating smart technologies in survey design will minimize time and financial burdens of clinicians and interviewers, while data can be reported in real time. By leveraging the data already collected from personal devices for long periods of time, studies could also minimize follow-up losses by providing automated data collection while ensuring the data are more representative than those obtained from the weekly fitness tracker use. So considering all of this, the goal of my work is to create a mobile platform that will collect and store health data from smart devices. The diverse and real-time data will be extremely relevant to public health officials in supporting their decision-making and health policies. Regarding how we'll accomplish this, we'll make use of Apple Health, which those of you who have an iPhone may be already familiar with. Apple Health is one of the most popular sources of health data from sensors, collecting information from devices that are connected to Apple operating systems. In this way, it acts as a repository for health data in Apple products, integrating information from activity to sleep, heart, and vital tracking, among others, as shown on the screen. These are all the categories that Apple Health collects data for. So to this end, we're developing an iOS app that connects to Apple Health and extracts user health data. The app will allow users to select which data they want to share, and public health agencies will have access to anonymized data to ensure the privacy of individuals is being respected. I'll discuss a little bit more on privacy later in the presentation. To validate the accuracy of the collected data, stress will be used as a use case. We'll conduct a study to collect stress-related variables from working age individuals in real-life scenarios with the platform. This data will be used to train machine learning models to predict the stress levels of each individual, which will hopefully demonstrate the effectiveness of the platform. Since stress is typically collected through self-report, despite associations with objective metrics that can be collected with the Apple Watch, such as heart rate, sleep, blood pressure, we hope it's going to be an ideal use case to test the accuracy of the platform. To collect the ground truth on stress, we will use the perceived stress scale, the PSS5, which is a questionnaire which asks respondents to rate their feelings on a scale of 1 to 6. The feelings assessed are cheerful, happy, angry, nervous, and sad. At the end, participants will have a score between 1 and 30, with the positive feelings being negatively assessed because we're trying to measure stress. Participants with a score between 1 and 15 are going to be considered in the non-stress category, and participants with a score of 16 to 30 will be considered stressed. So this is the study design. In 3-hour intervals throughout the day, we'll ask respondents to fill the PSS5 questionnaire and collect the necessary data. Respondents will be able to fill the PSS5 through a smartphone application, the same one that they will use to collect the data. Steps can be continuously collected throughout the day with the Apple Watch, but heart rate and blood pressure must actually be activated. The user must actually do an action to collect this. And so this will be collected periodically throughout the day. In short, 5 times during the day, plus before sleep, respondents will provide their subjective stress self-report and collect the sensor data. At night, we'll collect sleep data, including total sleep time and number of times the respondent woke up. The heart rate, we'll collect heart rate metrics with the Apple Watch. Specifically, we'll collect heart rate in beats per minute and focusing on heart rate variability metrics, which represent the time interval between successive beats. The Apple Watch typically uses PPG technology, which they basically shine a green light at the wrist to measure the pulse. And this will collect the standard deviation metrics, the SDNN of heart rate variability. Currently, and unfortunately, that is the only heart rate variability metric that is supported by Apple Health. And another limitation is that the Apple Watch doesn't collect this information periodically. So the only way to collect it is through the Breathe app on the Apple Watch, which is a mindfulness application that asks respondents to breathe for a couple of minutes. So we'll have to ask respondents to activate this application at the moment of data collection. Fortunately, the new Apple Watch allows users to take ECG, which collect heart rate data in daily life scenarios. So the ECG signal will allow us to extract more features than the SDN from heart rate variability metrics. We're basically studying right now the possibility of integrating this new ECG feature into our study design. As far as we can tell, no study investigated if the signals from Apple Watch ECGs can successfully predict stress, although theoretically there is no reason to assume that they can't. So it will be interesting to see if this new feature can successfully be integrated in research. Since the Apple Watch has these limitations that I mentioned related to the interval of sensor collection, and the ECG data is not validated for stress prediction, we will also complement our analysis with the use of the Empirica E4 wristband, which is a medical grade wearable device that collects heart rate continuously throughout the day. the empirical A4 data, we'll also be using the structure prediction models. So it might be interesting because we can compare accuracies using only the device and using only the Apple Watch and using both. While Apple Health supports blood pressure data, the Apple Watch itself does not measure blood pressure. So we'll use some other sensors to complement our analysis. For blood pressure, we'll make use of the Withings Blood Pressure Monitor Connect, which is a wireless blood pressure cuff that is supported by Apple Health, and it can collect systolic and diastolic blood pressure. The Apple Watch does collect sleep data, so we'll track sleep using this device. Since sleep is a very new Apple Watch feature, however, we'll also make use of the Withings sleep device, which is a tracking mat that you put below your mattress, as an additional source of sleep data. So the table in this slide briefly summarizes the data and the sensors that we'll be collecting and using throughout the study. So steps data, which are the number of steps throughout the day, will be collected with the Apple Watch and the iPhone. Sleep data, including time spent awake in bed and time asleep, will be collected with the Apple Watch and the tracking mat. Heart rate and heart rate variability will be collected with the Apple Watch and the empirical A4. And ECG data will be collected with the Apple Watch. Finally, blood pressure data, which will be the systolic and diastolic blood pressure, will be collected with the Withings BPN Connect wireless cuff. Going back to the actual mobile application, we'll evaluate the proposed platform according to these attributes. So simplicity is related to how simple the system is. This will be evaluated by a respondent questionnaire at the end of the study. Flexibility is related to the adaptability of the system, and this will be achieved by the successful implementation of features that allow researchers to add new variables they want to collect. So we hope that in the mobile app, there will be like a plus sign, for example, where the researcher can click, see all the available variables that he can add or remove from the study. And then this will allow the system to be flexible enough to account for different study types. Data and information quality, which will be evaluated according to the successful creation of the stress prediction model for the collected data. Acceptability related to the willingness of people and organizations to participate in the system, and will be valued by a questionnaire to respondents and public health agencies. And user experience, which should be evaluated by a questionnaire at the end of the study. In addition to machine learning models, which are represented here in the flowchart to the left, just a quick side note here, I'll be using support vector machines, or SVMs, and random forest as the machine learning models. I think this is a little bit too technical, and honestly, this is not my focus. My focus is more on the mobile application, so I'll not go into the detail of this here, but if anybody has any questions about this, feel free to ask me at the end of the presentation. So in addition to the models, we also want to conduct statistical testing to examine if there are any statistically significant differences in the collected data with the platform in the stressed and non-stressed groups according to the PSS-5 questionnaire. So to this end, we'll use a dependent t-test in case data is normally distributed, and the Mann-Whitney U-test in case the data is not negatively distributed. For machine learning models, we'll use support vector machines and random forests, like I just mentioned, as these are shown to have higher accuracy when predicting stress according to the available literature. In terms of privacy of health data, which is something that we need to consider when talking about collecting user information, in Canada, the Protection and Electronics Document Act, or the PAPIDA, is a federal act that regulates the collection, use, and disclosure of personally identifiable information, or PII. Several provinces have adopted health sector laws dealing with personal health information, some of which are deemed substantially similar to PAPIDA. And PAPIDA still applies when personal health information is transferred across provinces or across countries. Without getting into too much detail on PAPIDA, the principle of safeguard states that PII must be protected by security safeguards appropriate to the sensitivity of the information. So what will constitute an appropriate safeguard will depend on the sensitivity of the information and the data custodian circumstances, including the type of organization and the data is being shared with third parties. In order to avoid complications and respect privacy and security while also respecting PAPIDA, the data collected through the proposed application must be anonymized. So personally identifiable information typically has direct identifiers, which directly identify an individual, such as email, phone, and social insurance numbers, and quasi-identifiers such as date of birth, postal code, and first name, which can be used in conjunction with other data to identify an individual. We'll anonymize all collected data in the platform by removing the direct identifiers, and so we hope to ensure the privacy of individual data being collected. We'll also make sure to collect consent from every individual before data collection. Apple Health does have a consent module implemented by Apple, and we'll implement also our own consent forms in the study. So at the end of the project, we hope to have three factors. A mobile iOS platform that automatically extracts Apple Health data for public health while respecting user privacy. Predictive stress models based on real-life data from Apple Health and identification of statistically significant differences in a population, and qualitative information on the use of the platform by participants and public health agencies. In addition, talking specifically about usability and design, it is important to consider vulnerable populations here, such as older adults. These populations are the most vulnerable, and therefore remote monitoring may be critical in determining and preventing risks for these individuals. So we conducted a review of possible facilitators and barriers to mobile adoption by older adults. In terms of facilitators, having previous technology experience contributes to the successful adoption of mobile technologies. These technologies can also give a sense of safety and security, connecting older adults to family, friends, and physicians, and allowing them to monitor health conditions. Having learning resources and peer support to help them understand new technologies, as well as easy-to-use systems and interfaces, also greatly helps. In terms of barriers, older adults have several impairments such as visual, hearing, motor, and cognitive, which can hamper their adoption of mobile products. In this context, it may be necessary to use alternative ways of providing a feature in the mobile application. For example, for older adults with hearing impairments, instead of using a kind of sound to tell them that something's happening in the app, we may have to use vibrations in the phone or flashing lights to indicate that something's going on. Other barriers include higher negative reaction to errors by older adults, which is increased by a lack of knowledge on the devices on the part of this population, and a lack of desire or necessity to use the devices and perceive complexity as well. So making this very easy, very easy to navigate and very simple interfaces, it's key here. And finally, considerations regarding the cost of these technologies and privacy and security must also be considered, and this may deter older adults from adopting these technologies. Now, we are not going to consider this in the first version of the platform. Right now, we just want to develop an app that's going to collect Apple Health data and successfully predict stress, but we hope to implement some of these insights into the next versions of this platform for public health agencies. Oh, sorry, I guess I recorded this from my video and the sound was there. To conclude, the platform being proposed here can improve several limitations in service. It can improve social bias by providing a secure space for participants to report information, diminish recall bias as information will be collected continuously, minimize follow-up losses since individuals do not require any additional effort for data to be collected from their devices, minimize delays for data report as the process of data collection and reporting will be automated, and improve cost and logistics as deploying an app to a large number of people is simple and cost-effective when compared to a survey. The platform also has the major advantage of leveraging data already with their smart devices and can improve limitations in service. Ultimately, with more robust, diverse, and accurate data, we hope that public health agencies will have a new tool to help in their mission of improving population health and saving lives. So thank you, and if you have time and if you have any questions, please let me know.
Yeah, thank you, Pedro. Yes, we do indeed have time for questions. If anybody has any, or please put all of your questions in the Q&A box for us. Chen, go ahead. What's your question?
Thank you. I appreciate this opportunity. So my question is that I see you're using Apple Watch and the E4 wristband, but they are all wearing on the wrist. So I'm wondering like which is on their dominant hand and which is on the other wrist.
That's a good question. To be honest, that's something that I'm kind of still studying, but I think the Emparica is going to go on the non-dominant wrist and the Apple Watch is going to go on the dominant wrist. The reason for that being that the Emparica is a medical device and their instructions do say go on the non-dominant wrist. The Apple Watch is more of an off-the-shelf wearable, and as far as I can tell, there really isn't a lot of difference between which wrist you're using it.
Thank you.
Just giving other people a chance to ask a question.
Yeah, I just saw Taylor raise her hand.
Taylor?
Yeah, I went to type it, but I can't seem to actually type any question.
Panelists are not able to access the question and answer box. You have to send it through a chat or raise your hand like you did.
Okay, my question is, how generalizable is it? Because I know you talked about a lot of public health, but I know not everyone can necessarily afford maybe a smart device like an Apple Watch or something similar on a different platform. Or do you have a way to account for that?
So, the question cut a little bit, but I think you asked how am I going to account for the costs? Like if I want to do an application for public health, how am I going to account for the costs of some of these technologies?
Or the generalizability, since not everyone can afford maybe an Apple Watch or a smart monitoring device like that.
So that's definitely a limitation. Even if you're not talking about Apple, if you're talking about Android, which is a little bit more accessible, we still have the limitation that not all populations have this. Older adults, for example, is one that's definitely going to be underserved at this. But the goal here is not to propose. So there is a couple of things here. The first one is that the goal is not to propose a comprehensive system that's going to replace traditional surveys, but hopefully to enhance them. So, for example, I mentioned that the Canadian Health Measure Survey is mostly a self-reported survey, but they ask the respondents to use a fitness tracker for a week. So instead of that, if we can access data that's been passively collected by your phone, since you got your phone basically, and if you have these devices, then this could be much better for public health agencies in helping to understand some of this, some of the behavioral information of populations. The other question is, at the end of the day, if you ask people to download an app and automate this process, this is going to improve logistics and costs much more than, say, having to call people, having to send questionnaires, emails, having to manage all of that. So if public health agencies are interested in using these devices for studies, they could potentially distribute this among a segment of the population as well. The only reason that we chose Apple Health and not Android product right now, well, the first one is that I do have a background in mobile OS development, so that spoke a little bit to my programming strengths, but also Apple Health is a little bit more advanced than Android devices in terms of the health data they collect. Android devices usually focus more on physical activity, and Apple, it began that way, but it's starting to move a little bit more towards data that can be helpful for this. So I definitely agree that that's a limitation, but the goal here is not to substitute, but rather to complement.
Thank you.
Thank you, Taylor. And that's all the time that we have for Pedro's questions. If you still have a question for Pedro, please feel free to contact him directly. His contact information is in the networking directory. Next up is Rongbing.
Okay, let me share my screen. Can you see it? Okay, so my name is Rongbing, and I'm also from the University of Waterloo. Today I'm going to introduce my current study, which is modeling pilot flight performance in a cognitive architecture. So today I'm gonna briefly introduce the model, which is including the background, structure, development, and future study. So the first thing is, sorry for that total. So right now we have developed a pilot model in the QNACTOR, which is the queuing network adaptive control of thought rational cognitive architecture. So the model can be connected to a flat simulator, which we are using the X-Plane 11 right now, and generates some human factors data, including the performance, mental workload, and the solution awareness. So the purpose of this model is support aviation research and interface design evaluation by generating simulated pilot performance data without human in the loop, which is the HITL trails. So which can reduce the spend, save the money, a lot of money for doing the research. So what is the ACTAR, which is the cognitive architecture we are using right now? It's a theory for simulating and understanding human cognition. So there are three main parts of this architecture. The first one is modules, the second one is buffers, and then the pattern matcher. So for the modules, basically there are two modules. The first one is perceptual motor, which is you can think it as the action. So the visual, the manual module, the oral module, etc. So it represents the interface with the real world. The second module is the memory module, which is representing the knowledge of your man. So there are two kind of memory. The first one is the fact. We call it declarative. For example, 1 + 1 is 2. That's the fact. So it is the declarative memory. The second one is procedural memory, which is made of productions. So for example, for pilots, all the pilots know how to operate a airplane after the training. So the knowledge the pilots gain within the training, we call it as the procedural memory. Then the buffers. So the buffers is represent the state of the modules. So for example, if a person is doing something by hand, then his manual module is active. So that's, we call it as buffer. And then the pattern matcher. So the pattern matcher searches the production that matches the current states of the buffers. So basically it's a connection between the production rule and the action module. So what is the QActor? QActor is an integration of the actor and the Q network. So the basic idea for QActor is multitask. So the original actor doesn't support multitask, but the QActor does. So the QActor has been applied in several areas. For example, like driver takeover performance in partially automated vehicles and the driver situation awareness, etc. And it's also open source, just like the original actor, and you can download it at this GitHub link. And then about the X-Plane. So X-Plane is a flight simulator developed by a company called Liminar Research since 1995. And it's the only one which is the FAA certified for training, education, research, and commercial purpose. And X-Plane can transmit data with external programs through the UDP, the user diagram protocol. So the model can connect to the X-Plane via UDP. So it can read and send the information from to X-Plane. About the model structure. So during the entire flight, a pilot must continuously observe the external environment and aircraft status by the visual modules, and then maintain communication with the air traffic control, ATC, by the oral modules. So those modules will process and send the information to cognitive cognitive stages for further processing. The procedural module will perform pattern matching based on the model's procedural memory and refer to its existing declarative memory to understand the current situation and perform certain operations. And then for the analysis of the pilot cognitive processing and behavior, we divided the cognitive process into 3 stages in a continuous cycle, namely monitoring, decision making, and control. So the monitoring means the pilot attends to external displays and perceiving external information through the visual or audio module. And the decision making basically matches the oral or visual modules with the buffer and send all those information to the pattern matching process. And then the control part means the module receiving the action commands and producing more control actions. So currently the model is still under development for two major scenarios during the flight. The first one is pre-flight preparation, and second one is a takeoff. So those two phases are represent two major types of interaction between the pilots and the aircraft. And the aircraft preparation phase mainly involves the pilot following the checklist to interact with equipment inside of the cockpit. So there is not much involvement with the external environment. The checklist is the series of discrete steps. In the takeoff phase, the pilot needs to continuously perform multiple subtasks, including monitoring airplane status, observing the external environment, communicating with ATC, and maneuvering the aircraft. So in the future studies, we will collect human pilot data from the same tests and compare human results with model results for model validation and improvement. So right now we are using the default values in QActor and Actor for our model. These parameters values have been shown to be suitable in previous modules for computer interaction. For example, the driving tests I mentioned earlier. And we have planned future studies in collect human pilot data from the examination and the validation of the models. We will recruit some student pilots from the University of Waterloo and then ask them to perform the same action mentioned earlier. We will record the various parameters and status of the flight simulator during the test, such as aircraft location, airspeed, flap rate, either angles, etc. And then we will also videotape the human pilot's performance during the examination. And then we will use the Logitech flight simulator system to build up cockpit, and it will connect to the PC, which is running the Explain 11. And then there are going to be 3 monitors in front of them to display the cockpit and external environments in Explain 11. And also the fourth flight has the electronic flight bag will also be provided to the students. Okay, that's basically all my study right now. Thank you so much.
Thank you very much, Rongbing. I appreciate it. Unfortunately, we do not have time for questions, but if you have a question for Robin, please feel free to contact him directly. His contact information is in our networking directly. And I want to thank each of our student lecturers and the audience for your questions. There's definitely been a lot of learning that was in this session, and we appreciate your contribution. I want to remind you that we've been playing bingo. Please submit your bingo card on our webpage by 4:15. That's 15 minutes from now to get your last bingos in and get that submitted. And that is for a chance to win a free student membership to HFES. Also, this was our final student lecture session, so please vote for your audience favorite, the most innovative and most engaging lectures. Your ballot is on the voting page, and it's also due in 15 minutes, due at 4:15. Our next event is a coffee break with a drop-in as you want to type of approach. And that room is open and ready now. It's hosted by Dan, and you can see the link for the event as well as the Padlet link, which we're using instead of the chat feature. That way you can come and go as you please, but still be fully in the loop on the conversation. And those are both on the session links page. I also just dropped them into the chat box. After our break, we will have our keynote debate on inclusive methods, and you can find the link to that on our sessions link page. The coffee break starts right now, and the debate will start promptly at 4:15. I look forward to seeing you guys soon.